Welcome to our podcast episode on cutting-edge approaches under development for the management of lung cancer in Canada. I'm your host, Anna Christofides. I am joined by Dr. Barb Melosky, who is a professor of medicine at the University of British Columbia and a medical oncologist in Vancouver at BC Cancer. Dr. Melosky specializes in the field of thoracic malignancy. She sits on the Executive Lung Site Committee for the CCTG Canadian Clinical Trials Group and is creator and chair of the British Columbia Lung Cancer Biobank. Today, she will be discussing some cutting-edge approaches for the management of lung cancer, including the use of artificial intelligence and the latest emerging therapies under development. Hope you enjoy it.
Hello, my name is Barbara Melosky. I'm a medical oncologist at the BC Cancer Vancouver site. It's my honor to talk to you today about really new therapies for lung cancer. I'm a lung cancer medical oncologist. I only treat thoracic malignancies. That's what I do. Sometimes people say, how do you know this and that? And it's the only thing I do. And I would encourage, just on the side, for the program directors, when they do their hires, sometimes they make these young oncologists do like 5 or 6 different sites. I would encourage them to try to, tone into those young oncologists, get them like figuring it out, which site is going to be their site. Because I think then you can really go to meetings and get educated and really be an expert in that site. Okay, that's aside. I wanted to talk today about several new therapies, new impacts, where I think the future is going. And in terms of doing that, I'm going to talk about first, artificial intelligence. It's here to stay. It can actually help us. Everyone's afraid that's going to replace us. It's not. I wanted to talk about vaccines. We've been working on vaccines for 20 years. We're getting better and better at it. And I think those are also in our future. And I've been asked to do a phase 3 trial on a vaccine that's super interesting. And finally, I wanted to talk about a class of molecules called BITE. These are bispecific T-cell antibodies, and they're also here to stay. We've been thinking of, those type of treatments being for lymphoma, myeloma, et cetera, but really they're coming into the solid tumor world. In terms of BITE, I think the first BITE we're going to see is that molecule, that there's actually 2 of them out there for small cell lung carcinoma. In terms of what it's doing is actually getting the T cells engaged and going to attack the tumor. So it looks really exciting time for that. In terms of the evidence that I've seen for that, if you look at the BITE that is made by Amgen, and there's another one by Boehringer Ingelheim, they look very promising. And the most interesting thing about them is that if you respond to them, the duration of response can be years. And in small cell lung cancer, we're seeing data in patients that are treated 3rd and 4th line. And if they respond, they're on those drugs for 2 more years. Can you imagine a time when extensive stage small cell lung cancer patients are living, 3-4 years? It's fantastic. So I think we're going to have to learn how to deal with their side effects, which are simple, but hospitalization is needed. And as a solid tumor lung cancer doctor, we're not really used to that. I think we can take advantage of our hematology colleagues and get their help, and how do we do this best? And, if I'm looking at the Amgen drug, they're getting better and better at it. They've moved the 48-hour hospitalizations to 24. They've reduced the drug, so less side effects, reduced the dose, so less grade 1 and 2 side effects. And I think it's going to end up doable. And, as I said to a meeting just a couple of days ago, that if I had small cell lung carcinoma, I would want one of these. I think the world is changing fast. If we look at all the checkpoint inhibitors that we have for immunotherapy, we really didn't have any of these 5 years ago or 6 years ago when they came storming onto our world. And, I remember patients asking me about immunotherapy 10 years ago, and I was like, no, that'll never work. And it does. So I think we have to keep an open mind about new therapeutics and, where the future is actually going. I'm going to start with artificial intelligence. AI is coming into our world, not just in cancer, but in everyday life. And where might it really fit in lung cancer? And I think there's a couple of areas that, to me, just make sense. And the first thing to say, it's never going to replace an oncologist, pathologist, respirologist, nurse practitioners, GPO. It's not going to replace a doctor, but where can it really help the doctors? And one of the things that we're kind of, in my world, I have a lot of patients who are EGFR positive, who are progressing on osimertinib. And one of the biggest reasons that was shown by Dr. Ramalingan from the FLORA trial, that when he tested plasma in those patients progressing on osimertinib, 15% were due to MET amplification. And that's really quite common knowledge, but MET amplification can actually be hard to actually see. And now, when Dr. Ramalingan presented his data, that was on NGS by the Archer panel, but you'll pick up more of them on tissue if you do the true FISH test for amplification. And that's very tedious, that's very hard for the pathologist, and I think that's where AI can actually be programmed to help. I think that if I was a patient, I was progressing, I'd probably want a tumor test over NGS, really to see if there was MET amplification. And, we now have 2 trials, INSIGHT 2 and Saffron, looking at MET amplified patients. One of them includes IHC, the other includes NGS, but both of them, FISH seems to be the gold standard. In terms of other uses for AI, in our center in Vancouver, we have 2 screening programs, one for smokers and one for non-smokers. And, the respirologist is looking at CT scans that are low dose, non-contrast, and having to look at the lesions, count the lesions, decide if they're semi-solid, et cetera, decide if they need further investigations. And I think this is where AI actually might help a lot, and probably already is. So I think screening, those kind of things, can really be helped by artificial intelligence. Now, will it ever replace pharmacy, making drugs or drug levels? I don't think so. There's too much room for disasters or mistakes. And believe it or not, the human error is actually, I think, less. When a pharmacist mixes a chemotherapy drug, is checked by multiple pharmacy, the order is written by an oncologist, et cetera, et cetera. Radiation is another great example where AI has already come into place, where they can now look at a patient and 3D dimension planning and deliver radiation to the tumor, not to good, normal, healthy tissue. So, keeping an open mind for artificial intelligence is so important. Its role is going to save us time and effort. So please remember that, because I hear a lot of negative things about it. It's not going to replace us. So think of that as well. All right. So what are the exciting new treatments in lung cancer? I'm going to start with vaccines. We've just sort of lived through, although the COVID pandemic is still on, we've just lived through, where it's been a hard couple of years. But we've also gotten some great technology out of it. And if you remember, the Pfizer vaccine was followed by other vaccines. These are RNA vaccines that are now made very quickly, and I think can be applied to cancer or oncology. And what I'm thinking of is really a trial that I was asked to participate in, where a tumor is given a regimen of immunotherapy, then the tumor is taken out, the neoantigens of the tumor and their background is sought out, and then an RNA vaccine is made. And with that, the vaccine then can be given back to the patient with or without pembrolizumab, so that the checkpoint inhibitor can go directly to the stimulated antigens where the cancer might be. So I think that's really exciting. We've been looking at vaccines for oncology for 20 years, but this new sort of RNA vaccine, and the current trial that I've been asked to do is Moderna and Merck, but they showed great promise in melanoma. We're doing the phase 3 trial here where the melanoma doctors are, as well as the trial in renal cell, the trial in bladder, and I've been asked to do the lung. So, a busy, busy time for that vaccine, and there'll be others. So, if Moderna can make a vaccine looking at that tumor, so can other people. Now, the other sort of really big change that is coming up and it really exploding in our world, and it's really the antibody drug conjugates. They started many years ago in breast cancer, but now they've exploded in lung cancer. And it's really, if you think of it, what is an antibody drug conjugate? Well, it's an antibody. it can be made to wherever you want to go on the cancer cell, and it's attached with a linker to a chemotherapy drug. So the antibody goes towards the cancer, gets internalized, and then the chemotherapy drug is released. So kind of like targeted chemotherapy. And, we've had some negative trials, the first being in small cell with Rova-T, but we've had some positive trials. TROP looks a really interesting target. I think that there's, HER3, another really interesting target in osteoburden resistance. And in all patients with lung cancer, HER3 is actually expressed in many non-small cell lung carcinomas. In fact, some would say even all of them. So I think that whole world is developing quickly. And many, many partners, many, many ADCs, and the every time I give a talk, the table gets larger and larger and larger. And I think that, that the next big thing besides antibody drug conjugates is, we're giving all this immunotherapy and for non-driver mutation tumors, but it's not perfect. And yeah, we're seeing, in some cases, 30% of the patients alive at 5 years, but what about the other 70%? So how can we make targeting the immune system better? And that's a lot of research that's going into that today in terms of TIGITs, in terms of LAG-3, in terms of new molecules, in terms of priming the immune system. It's a big area with a lot of research, but that is the big, I think, step that the scientists are actually working towards. How do we make these drugs good for all tumors, not just the lucky ones that respond? How do you make, cold tumors hot? And that's sort of the big question in the world of immunotherapy. I wanted to end this really with talking about chemotherapy because, most chemotherapy drugs are off patent. Are they still going to be in the future of lung cancer? And the answer is I think yes. I might be wrong. You might, tell me in 10 years that I was wrong, but they certainly still have an overall survival advantage in the adjuvant setting. They still make drugs like pembrolizumab work even better. They still are important to give combined with chemoradiation for stage 3 cancers. So as much as, patients are scared of chemotherapy, and as much as they're not really targeted towards the tumors, some are histologically pemetrexed that works better in adenocarcinoma than squamous. But on the whole, they really go throughout the body and can do damage in many places. But they're not going away. They seem to add to the treatment of almost everything we do. And, I'll give you an example. Think of the FLORA-2 data. This is patients in the first-line setting with stage 4 non-small cell lung carcinoma. They're positive for EGFR mutations, the common mutations. And adding chemotherapy to that made it even better. It was recently approved by the FDA and is at the jurisdictions right now in Canada. And it just wasn't making chemotherapy better. It was more than just adding, osimertinib and chemo. It looks better, the two of them in sequence. So that's really exciting. And, people can put down chemotherapy. It affects the bone marrow. Sometimes it affects the hair. Fatigue is a big problem, marrow suppression, needing GCSF and sometimes platelets and blood transfusions. But it's still one of the biggest tools we have. And would it be nice to get rid of it? Yes, if you can find something better. And so I think it's actually here to stay till you find something better. So we've talked about many things today. We've talked about artificial intelligence, which I think is going to play a big role in screening. We've talked about, the role of vaccines, which I think also, I'm going to do that trial. It's super, super interesting because of COVID and being able to make these RNA vaccines very quickly. We talked a little bit of the new world of cell-directed therapy like BITE and CAR-T, and we're going to have to learn to deal with them because they're expanding as well. And finally, we talked about chemotherapy, and I think exciting note, we've learned how to deal with chemotherapy, but it looks like it's making all the other new therapies better. So I wanted to thank you for your time. I wanted to thank Sanofi. Sanofi allowed this to occur through an unrestricted grant. So thank you, Sanofi, for helping all of this. And I'll say goodbye, and I'm happy to answer any questions by email, bmelosky@bccancer.bc.ca.
you.